In this presentation, I wanted to go through some of our ASCO updates from our meeting in June. The abstracts I was going to focus on were for the HER2 positive metastatic breast abstracts. Okay. Um, Going. So the three abstracts that I wanted to discuss today, the first is the Emerald study. This looked at first-line HER2 positive metastatic breast treatment, incorporating eribulin in the first line and comparing that to taxane. The second abstract is the Patricia cohort, looking at combination of CDK4/6 inhibitor with endocrine therapy and Herceptin in the metastatic setting. And then the third abstract is the Destiny Breast 07, which is first-line treatment with TDXD in combination with pertuzumab. So the first one I wanted to talk about is the Destiny Breast 07. So this was a dose expansion study looking at first-line treatment with TDXD versus TDXD in combination with pertuzumab for previously untreated HER2 positive metastatic breast cancer. So as we know, current first line of treatment for HER2 positive metastatic breast cancer is a taxane-based treatment with Herceptin and Perjeta, which is based on the Cleopatra study. And then we also have seen the efficacy of TDXD monotherapy after progression of that first line therapy, and that's based on the DBO3 study. So Destiny Breast 07, it was a phase 1B/2 multi-center open label study that looked at safety and tolerability for TDXD alone or in combination with another HER2 positive agent in this setting, in this case, pertuzumab. So these participants should have had no prior therapy in the metastatic setting. And the data that they presented at the meeting, this was an interim analysis of for the dose expansion phase of TDXD alone or in combination with pertuzumab. So patients were enrolled, the eligibility criteria being HER2 positive disease, which was either by either being IHC 3+ or 2+ FISH positive. If they had evidence of current or brain mets, they were not eligible for this trial. Any prior therapy for in the metastatic setting was not also allowed in this trial. And they had to have a disease-free interval of at least 12 months or more from their adjuvant HER2 therapy. So 75 patients were in the TDXD monotherapy arm, and there were 50 patients who received TDXD with pertuzumab. The primary endpoints for the study was safety and tolerability, and then their secondary endpoints were overall survival, progression-free survival, and duration of response. In terms of the patient characteristics, 60% of the patients had de novo metastatic disease, and among those who did have recurrent disease, over half of them had received only trastuzumab, and only a few of them had previously received pertuzumab. The treatment side effects were fairly tolerable, manageable. The most common one was nausea. Grade 2 diarrhea was more common for TDXD in the TDXD with pertuzumab arm. ILD was also slightly higher in this group as well, but there were no grade 4 or grade 5 adverse events that were reported. In terms of response rates, the overall response rate was 76% for TDXD alone versus 84% for TDXD with pertuzumab. And then for those participants that had a complete response, 8% had a complete response with TDXD alone, and then the combination arm, there were 20% of their participants had a complete response. For progression-free survival, they evaluated progression-free survival at 12 months. And as you can see on this Kaplan-Meier curve at that 12 month, there was a clear separation in the curves at that point. And so the difference was about 9%. So 89% had progression-free survival for the combination arm versus 80% in TDXD alone. And this was a median follow-up of 24 months in both arms. So I think take-home points from this study, I think we're all kind of waiting for the data to be reported for TDXD monotherapy in the first-line setting in comparison to our taxane-based regimen. But this data does show us that maybe there is also an added benefit to with pertuzumab in addition to TDXD first line. So I think more to come about for these trials. The next abstract that I wanted to talk about, this is the Emerald study. So this is a different, we have the Emerald study and with elacestrant. This is the Emerald study that was conducted in Japan. This was a phase 3 trial that looked at trastuzumab with pertuzumab in combination with eribulin versus taxane for first-line treatment in the metastatic setting for HER2-positive disease. So as we know, eribulin is a microtubule inhibitor. It has been shown to improve overall survival in heavily pretreated metastatic breast cancer patients. There's phase 2 data of equivalent efficacy of eribulin with Herceptin versus docetaxel with Herceptin. So the Emerald investigators previously reported phase 2 data of eribulin with HP, and that showed that there was a median PFS of 9.2 months and a response rate of 60.9%. And so based on that background information, the Emerald study then performed a phase 3 study in Japanese patients that were HER2 positive, either locally advanced or metastatic, and they were testing specifically non-inferiority between eribulin and taxane when used with HP. The study had patients enrolled. They were not to have had any prior chemotherapy that excluded TDM1 in the metastatic setting. And they were randomized 1-to-1 with eribulin or taxane in combination with Herceptin and Perjeta. Primary endpoint was PFS, and the secondary endpoints of the study were overall survival, overall response rate, and duration of response. And so for their primary endpoint, which was progression-free survival, the median PFS for eribulin was 14 months versus 12.9 months with taxane. And their hazard ratio was 0.95, so this did meet the criteria for non-inferiority that they defined by the study. In terms of the median overall survival, in the taxane group, this was 65 months for overall survival, and they did not meet overall survival. It was not reached, sorry, in the eribulin group. And the mean, one thing that the presenters did note was that the mean duration of response was slightly different between the two groups, with participants being on eribulin longer than they were on the taxane, about and on average 28 weeks with eribulin versus 18 to 20 weeks with taxane. In terms of the safety, the treatment-related adverse events that were more common with the eribulin were neutropenia and neuropathy. I think interestingly, what was reported in this study, that there was a higher incidence of neuropathy in the eribulin group, 61% versus 52% in the taxane group. I think real world, we don't necessarily see that, and the neuropathy tends to be a bit less severe with eribulin versus taxane. So that's and one thing to point out about what was reported in here. They did note that skin events and diarrhea and edema were more common with taxane. So I think take-home points from this study is showing that, for those select patients who you are worried about giving taxane in the frontline setting, whether that be maybe they do already have severe neuropathy or any other reason that would prevent them from receiving taxane, eribulin seems to be a good option, and the study did meet its endpoint of non-inferiority. Now, the last abstract that I wanted to discuss, this was the results from the Patricia cohort C study. So this was a phase 2 trial that looked at CDK4/6 inhibitor palbociclib with trastuzumab and endocrine therapy for pre-treated HER2 positive and PAM50 luminal metastatic breast cancer. So as we know, CDK4/6 inhibitors are approved in the first-line setting for hormone receptor positive metastatic breast cancer. And it was the Monarch-HER study that showed an improvement in progression-free survival with abemaciclib in combination with fulvestrant and trastuzumab. And that was in comparison to chemotherapy versus trastuzumab. And then we also know that the intrinsic molecular subtypes that uses PAM50 analysis can also identify patients who may benefit from endocrine therapy with a CDK4/6 inhibitor and in combination with HER2 therapy. So in the Patricia study, they initially had cohort A and B, which looked at palbociclib with trastuzumab and endocrine therapy. And that looked at safety and feasibility. And what they found was that for those who had that PAM50 analysis that were luminal A and B subtypes, they had a superior progression-free survival compared to the non-luminal subtypes. So then what the investigators did is they performed this prospective study, which they named the cohort C, which is what was presented at ASCO. And that was for metastatic patients who were triple positive, so HR positive and HER2 positive, with this, who were classified as luminal A or B tumors based on that PAM50 analysis. And this was to further explore that treatment combination in terms of efficacy. So the study was an open label, multi-center phase 2 randomized control trial. This included both premenopausal and postmenopausal women and men as well, who were hormone receptor and HER2 positive that had metastatic breast cancer. And again, they had to be identified as luminal A or B by PAM50. Other eligibility criteria, they had to have at least 1 line of prior therapy. So this is different than the other 2 abstracts I presented, which were all first-line treatment. And they did allow patients with CNS disease, but that had to be stable CNS disease. Those who had prior CDK4/6 inhibitors were not eligible for the trial. So they randomized patients to receive either palbociclib in combination with trastuzumab and endocrine therapy versus treatment of choice. And that was either TDM1 and then endocrine therapy or chemotherapy with trastuzumab. The investigators did not allow TDXD or tucatinib as treatment choices for the control arm. The primary endpoints for the study was progression-free survival, and then the secondary endpoints were overall response rate. And they did report that the trial closed prematurely. They had enrolled 73 patients at that point, but they did close early due to low recruitment, and it was underpowered based on their pre-specified control assumptions. So median follow-up time was 27.6 months. In the palbo Herceptin endocrine therapy arm, median progression-free survival was 9.1 months versus 7.5 months in the control arm. So a difference of about 1.5 months. But it was statistically significant with a hazard ratio of 0.52. And in terms of adverse events, so the rate of grade 3 adverse events was 51.3% in the treatment arm with the CDK4/6 inhibitor and Herceptin versus 28.1% in the control arm. So pretty significant difference in terms of grade 3 events. As not surprising. The most common adverse event was neutropenia, and this was also the most common event that required a dose reduction, and also most frequent grade 3 adverse event in that experimental arm. So although this trial, didn't had to prematurely close, I think that the importance of this data to show that there is, safety with using CDK4/6 inhibitor in combination with HER2 therapy. But in terms of having more finalized data to see about efficacy, we're still waiting for that to come. So that was all that I had prepared today. I can open it up for any questions about those three that I discussed.
Are you doing anything different in your practice based on those three abstracts you presented?
I think the only of the three would probably be, considering that eribulin in the first line setting versus the taxane for, again, a very specific patient. But I think the rest of the data is still kind of premature in terms of the other abstracts.
I think the problem there, Vidya, is it's not covered. So eribulin is supposed to be second line. And so this data is going to be needed to get that covered. You can say it's second line if you've already given adjuvant paclitaxel and argue it. But eribulin is extremely well tolerated, especially in the low dose metronomic fashion that we've published. And, there were a couple metastatic patients who we cured in that publication. It's a really great combo, and I think everybody knows it. But the insurers have been denying it. So I think we need the maturity of that data in order to change the coverage.
I inherited one of those, Hannah. It's actually really fun. She's like 10 years out, and we're considering her for the Stop HER2 trial because she got eribulin and is 10 years out with no evidence of disease.
It's ridiculous. Yeah. Anyway, but I think that the real reason that study got done was to get coverage for this niche. And I don't think presenting it at ASCO is going to be enough. It's going to have to be a peer-reviewed publication, and the FDA is going to have to take it on, and they're going to have to change the label. And I don't think any of that has happened yet. So you may be thinking you're changing it in your practice, but you won't be able to do that and get approval, unfortunately. Even though it's, I think, quote, the right thing. And especially if you give the low dose metronomic fashion, you don't have the neuropathy and thrombocytopenia and the other Achilles heels that we saw with the FDA approved dosing. So this is going to be interesting. But I think you did a really lovely job of presenting, some important abstracts in a field where, we're wondering if we're overtreating.
Just to add, I think we also knew from an old trial called the Velvet trial that looked at eribulin with tras and pertus from a few years back, that how incredibly effective that compound is. I think the bigger question is that there's ADCs now. As Eisai has an ADC that uses eribulin, and the question is, how do you show benefit over the drugs on their own? It'll be interesting to see if there's better safety or efficacy as that moves forward. Great job.
Thanks, everyone. I will stop sharing my screen.
And I will try to start sharing mine. Can everybody see the screen okay and hear me okay? Okay, well, I didn't hear anything, so I'm going to keep going unless someone tells me that there's a problem.
You're good.
Thanks, Nancy. So I'm going to present my updates. I had also presented at one of the Binatera Best of ASCO and had focused on triple negative. So I'm going to be largely focusing on triple negative today as well, but also threw in a couple extra topics at the end, including the Destiny 06 trial, which I think is important for us all to chat about. So we'll try to leave time to get to that as well. I have no conflicts of interest or financial disclosures, and I'm going to start by focusing on the talks related to early and locally advanced triple negative breast cancer. So the first trial that I was going to share with you all was the ABRAVE trial, which was a phase 3 randomized trial of avelumab in early TNBC, either for patients with residual disease after neoadjuvant chemotherapy or high-risk disease after primary surgery and adjuvant chemotherapy. So again, these were deemed to be high-risk patients who had completed local, regional, and systemic therapy with curative intent. There were standard eligibility criteria in terms of age and functional status. And then there were two different cohorts of patient. Cohort A was essentially patients who were being treated adjuvantly. For these patients had to be a T2N1 or a T3 to 4, N0 to 3, or a N2 to 3 with NET status. And then stratum B was post-neoadjuvant patients who had residual disease in either the breast or lymph nodes at the time of surgery. And then patients were randomized in a one-to-one fashion to either receive observation or avelumab. And there were a total of 477 patients on the study. So in terms of results, there was no significant difference in disease-free survival, either in stratum B or in the intention to treat group. However, there was a significant difference in overall survival in the intention to treat group. With a p-value of 0.035. And there was also a significant difference in distant disease-free survival in the intention to treat group with a p-value of 0.027. And so these are just summarizing the key findings here on in terms of disease-free survival, overall survival, and distant disease-free survival. Again, there was no real difference in disease-free survival, but there was a significant improvement in overall survival and distant disease-free survival. The toxicity profile was what we would expect with immunotherapy and was overall well tolerated. And I'll talk about this with the next study I present as well. But I think the major limitation here is that this study was designed and implemented really in the pre-Keynote 522 era. And so I think our standard of care and practice has shifted now, and many of us are already incorporating immunotherapy as part of the Keynote 522 regimen. So the next study I was going to share was a randomized multicenter study, phase 3, comparing anthracyclines followed by taxanes versus anthracyclines followed by taxanes plus carboplatin as neo or adjuvant therapy in patients with early TNBC. So in this study, triple negative patients who were either lymph node positive or negative with a tumor greater than 2 centimeters were randomized to receive AC followed by a taxane or AC followed by a taxane plus carboplatin. And so here the primary endpoint was event-free survival. And you can see that in the carboplatin arm, there was a significant difference with a hazard ratio of 0.67 and a p-value of 0.012. So in the intention to treat analysis in the carbo arm, the 5-year EFS was 82.3% versus 75.1% in the control arm. And they, for the sake of time, I won't go through the whole subgroup analysis so that we have time to get to some of the other topics. In their secondary endpoints, there was no major significant finding. There was no significant difference in IDFS, DRFS, overall survival, or PCR rates. And so essentially, the key findings from the study were that the addition of carboplatin to standard anthracycline followed by taxane therapy improved event-free survival in patients with early TNBC, but there was no significant difference in overall survival or PCR rate. Again, the safety profile here was consistent with known toxicity with these medications. There was no major differences in quality of life. I think putting these last two studies together, we essentially get the data that we know from Keynote 522, which is adding carboplatin and immunotherapy improves outcomes in our patients with early TNBC who are stage 2 or 3 disease. And so I think in our neoadjuvant population, these studies are not particularly practice changing as we've already implemented much of this into practice. I think where this comes into play for me is that if you had a patient who had upfront primary surgery and is found to have higher risk disease than anticipated, you may consider the addition of carboplatin. I would also anticipate it's, as Hannah was saying, similarly with erubulin, I don't know that we're going to be able to get avelumab covered in this patient population yet, but I think, again, in high-risk patients, potentially a case for incorporating some of these things in the adjuvant setting if they didn't have the opportunity to receive it in the neoadjuvant setting. And then moving on to metastatic TNBC, I won't spend too much time on this topic because the results were essentially negative, but this was a study looking at enfortumab vedotin in both hormone receptor positive HER2 negative patients and triple negative breast cancer. Here, this was locally advanced or metastatic breast cancer patients who had received prior taxane or anthracycline, and they needed to have received at least one standard of care cytotoxic regimen, but not more than 2. For hormone receptor positive patients, they had to have received prior endocrine therapy with or without a CDK4/6 inhibitor. And for triple negative patients, they should have received PD-L1 based therapy if they were candidates for it. And so patients in this study received enfortumab vedotin days 1, 8, and 15 of a 28-day cycle and continued treatment until disease progression. The primary endpoint in this trial was overall response rate, and secondary endpoints included PFS, OS, safety and tolerability, as well as DOR and DCR. And then an exploratory endpoint was Nectin-4 expression. So here, for objective response rate for triple negative breast cancer, it was a 19% ORR, and 8 patients out of 42 had confirmed responses. For disease control rate, it was 57% of TNBC patients. And then just another interesting finding, which I think continues to be a theme with our antibody drug conjugates, is that response was actually not dependent on Nectin-4 expression in TNBC patients and the HR positive cohort. Again, I was focusing on triple negative for the purpose of this talk, but Nectin-4 expression was not significantly different in terms of response rates. And then in terms of other secondary outcomes for median PFS, the median progression-free survival in triple negative patients was 3.5 months, and the median overall survival was 12.9 months. So overall findings from the study were that there seemed to be anti-tumor activity in both cohorts, but ultimately the pre-specified endpoints were not met. Safety was manageable and consistent with previous reports. And then again, Nectin-4 was highly expressed in both cohorts, but regardless of expression levels, the responses were essentially regardless of expression levels. All right. And then the other topic that came up was sacituzumab tirumotecan. I know we actually presented a bit of this recently as we were reviewing this for one of our own research studies, but this was the Optitrope trial. So this was looking at sacituzumab tirumotecan in patients previously treated with locally recurrent or metastatic TNBC. And this was a phase 3 study. So as a reminder, sacituzumab tirumotecan is an antibody drug conjugate using sacituzumab, which targets TROP2, and then it's linked to a novel topoisomerase 1 inhibitor with a relatively high DAR of 7.4. This has a novel linker that allows release of the payload both in the tumor microenvironment and inside cells to have a balance between safety and efficacy. And so for this trial, patients had to have relapsed or refractory disease to 2 or more prior chemotherapy regimens or unresectable, locally advanced, or metastatic disease. For prior therapy, one could be in the neoadjuvant setting if they had progression during treatment or within 12 months after, and patients had to have received a taxane, which could be in any setting. Patients were randomized 1-to-1 to receive the sacituzumab TMT or physician's choice of chemotherapy, which could include eribulin, capecitabine, gemcitabine, or vinorelbine. And then primary endpoints were progression-free survival. Secondary endpoints included overall survival, PFS by investigator assessment, ORR, DOR, and safety. So for PFS, I think this was one of the more exciting curves that we got to see. The progression-free survival for sacituzumab TMT was 6.7 months versus 2.5 in the chemotherapy of physician choice arms, with a hazard ratio of 0.32 and a very significant p-value. For overall survival, the data wasn't yet mature, but at their interim analysis, the median overall survival was not reached in the SACI-TMT group and was 9.4 in the chemotherapy group, with a hazard ratio of 0.53 and a p-value of 0.0005. They also here looked at response based on TROP2 expression levels, and similarly found that compared to chemotherapy, sacituzumab showed benefit regardless of TROP2 expression level. So the absolute level of TROP2 didn't seem to affect patient response. And I believe that's similar to what we've seen in the ASCENT and other trials that have analyzed this. And then just a couple other trials of interest. So I wanted to point out TBCRC 048, which was looking at a phase 2 study of olaparib monotherapy in metastatic breast cancer patients with germline mutations in PALB2 or somatic mutations in BRCA1 and 2. So what they found was a high overall response rate with olaparib in patients with metastatic breast cancer and a germline PALB2 mutation. And they saw a meaningful overall response rate in patients with the somatic BRCA mutations. However, more predictors of response was needed. And then I won't go too much into this, but there was also some data presented looking at BRIA-IMT, which is an allogeneic whole cell immunotherapy that I know we've had some interest in. So this is a randomized phase 1/2 trial to evaluate safety and efficacy of the BRIA-IMT regimen. Overall, they found that it was well tolerated. Most common side effects were fatigue and injection site reaction. And then there were promising results across subtypes in terms of overall response rate. And they also observed some CNS responses. Excuse me. So my takeaways for TNBC were that there is an ongoing need to identify better therapies for triple-negative breast cancer. I don't think there was anything particularly earth-shattering, though I do think the ADCs continue to show promise and gain a lot of interest and attention from all of us. I think things to keep an eye out for continue to be Dato-DXd and then sacituzumab TMT. So I think those are both exciting things on the horizon. In terms of things that are practice changing now, for patients with a germline PALB2 mutation, there appears to be benefit from olaparib in the metastatic setting. And then, as I said earlier, I would consider incorporating carboplatin into adjuvant treatment for high-risk patients who did not get Keynote. So I think those were the big practice-changing things for me in the triple-negative setting. Jen, if you want, I can pause after triple-negative, or I can jump in to talk about Destiny-06, whichever would be best.
Maybe we've got a second here, I guess, if there are any burning questions. I think I know we're all curious to see the results of the SWOG study looking at adjuvant pembrolizumab, and it will be, I think, some overlap between maybe the A-Brave was sort of a preview for what to see there, but I think a larger trial certainly. So just looking in the chat, any other questions?
Right. If not, I'm happy to move on and
Sounds
talk
good.
about the Destiny 06 trial, which I think was one of the more exciting studies that we got to see presented at ASCO this year, and I think will be of interest to a lot of people. So happy to move on to that. So these are my bonus topics, which are actually pretty substantial and interesting topics that were covered at ASCO this year. So just looking to see if there's anything. Okay. So this was a study looking at trastuzumab deruxtecan versus physician's choice of chemotherapy in patients with hormone receptor positive HER2 low or ultra low metastatic breast cancer with prior endocrine therapy. And these were the primary results from the Destiny 06 trial. So this was a phase 3 randomized multi-center trial. The patient population being studied here was hormone receptor metastatic breast cancer for patients that were either HER2 low or HER2 ultra low, which was defined as being IHC score of 0 with faint membrane staining. And I have a slide that I'll show you all to demonstrate that in a few slides. For prior lines of therapy, patients had to have received at least 2 lines of endocrine therapy plus or minus targeted therapy for metastatic breast cancer, or 1 line for metastatic breast cancer with progression less than 6 months after starting first line endocrine therapy plus CDK4/6 inhibitor, or recurrence less than 24 months after starting adjuvant endocrine therapy. And so patients were randomized 1-to-1 to receive trastuzumab deruxtecan or physician's choice of chemotherapy. The options for physician's choice of chemotherapy could include capecitabine, Abraxane, or paclitaxel. Here, the primary endpoint was progression-free survival in HER2-low patients. Secondary endpoints were progression-free survival in the intention-to-treat population, which included both HER2-low patients and ultra-low, overall survival in the HER2-low population, and overall survival in the intention-to-treat population. Other secondary outcomes included safety and tolerability, overall response rates, and patient-reported outcomes. So a total of 866 patients were randomized in a 1-to-1 fashion. Again, the chemotherapies that patients could have received included capecitabine, Abraxane, or paclitaxel, with capecitabine being the most common. And the median duration of follow-up was 18.2 months. So here is the progression-free survival data from the HER2-low patients, which was the primary endpoint, and then progression-free survival in the intention-to-treat analysis, which included both the HER2-low and ultra-low patients. So in terms of progression-free survival for the HER2-low positive population, or HER2-low population, excuse me, the median progression-free survival was 13.2 months versus 8.1 months with physician's choice of chemotherapy, for a difference of 5.1 months. The hazard ratio was 0.62 with a significant p-value. And then in the intention to treat group, the data essentially looks very similar, with a median progression-free survival of 13.2 months, and then a median progression-free survival of 8.1 months in the physician's choice of chemotherapy group, again, with a significant p-value and hazard ratio of 0.63. So essentially, the trastuzumab deruxtecan showed a statistically significant improvement in PFS compared with standard of care chemotherapy in HER2-low patients and the intention-to-treat population. In terms of overall survival, which was a key secondary endpoint, that data is about at 40% maturity. So this was an interim analysis looking at 12-month overall survival rate. In the HER2 low group, the 12-month overall survival rate was 87.6% with trastuzumab deruxtecan versus 81.7% with physician's choice of chemotherapy. And then in the intention to treat group, it was 87% versus 81.1%. And then this was just looking at that subgroup analysis, looking at the ultra low patients. So here they were just reminding us how they defined HER2 ultra low. So HER2 low, as we know, can involve 2+ or 1+ staining on IHC. Ultra low was defined as patients who had a score of 0 by IHC, but had faint or incomplete membrane staining in less than 10% of tumor cells. So in the ultra low group, this was a pre-specified exploratory analysis. They had a median progression-free survival of 13.2 months versus 8.3 with physician's choice of chemotherapy. And the overall survival was 84% versus 78.7% at the 12-month overall survival rate. So this was consistent and similar to what was seen in the HER2 low group. And then in terms of side effects, side effect profile was similar to what we would expect and have seen with nausea and fatigue being the most common side effects. Other common side effects included alopecia, neutropenia, vomiting, and then decreased appetite, as well as leukopenia. And then in terms of pneumonitis, again, this is consistent what we've seen with other trials looking at TDXD, but essentially we do see pneumonitis in this population. Any grade pneumonitis was about 11% of patients, again, consistent with other trials. They did have 3 grade 5 events. So the key takeaway was that there was a statistically significant benefit over physician's choice of chemotherapy in HR-positive metastatic breast cancer following first-line endocrine therapy, including in the HER2 ultra-low patients. So I think, as we know, trastuzumab deruxtecan continues to show benefit and impressive results in these trials. I think for me, the question that comes up here is, as we see this sort of moving closer and closer towards the beginning of our lines of therapies, how are we going to stratify which patients we really want to use this for in that early line setting? You know, here it was after 1 line of endocrine therapy. Again, they sort of specified a higher risk endocrine population, but I think given, you know, that 10% risk of pneumonitis, I think for our slow, indolent, older ER-positive patients, you know, we may not want to be breaking out Enhertu in the second line. So I think we're going to need to continue to stratify which patients we want to use this for in that very early line setting, but clear benefit. And then I think another topic that came up a lot in discussion, both at ASCO and in the broader community, is, you know, how we're going to define HER2 ultra low. What is the best testing? Is that IHC? And then on that similar note, at some point, I think the question is, does it matter? Is it just that this is such a good medication that patients are going to get, the vast majority of patients are going to get benefit, and how much granularity do we actually need with that type of testing? So I think those were all interesting topics of discussion that came up around this. So I'm happy to pause there if we want to take a second to talk about it as a group. And then if not, I was also going to share one more topic that looked at AMH levels for our endocrine sensitive patients. I'm looking in the chat too.
Nicely done, Lynn. I think the question will be is AZ Daiichi looking to expand the label based on these studies? My guess is the FDA might want to wait a bit before that happens. We have committed to participating in the TBCRC study that I think Vidya is going to be our site PI for, looking at David Rim's technique of better quantification of HER2 expression, which may or may not help us kind of determine the best dosing in those patients most likely to benefit. Although, again, I certainly wouldn't want to ask our pathologist to go back and change anything that they're doing now based on this result, because it appears 0 is just fine.
Yeah.
And the numbers that are 0, that are truly 0 without any staining, seem to be very low.
Jen, do you want me to cover the AMH topic, or do we want to leave it for today?
I think we can, if you just the one more, I think we've got time. Let's go ahead.
Great.
If you're okay with that, thank you.
Totally fine. All right, so this was the last topic that I was going to share. So this was looking at serum AMH levels to refine identification of premenopausal patients with hormone receptor positive, HER2 negative, node positive breast cancer, most likely to respond to benefit from adjuvant chemotherapy. So for background, as most people in this audience are aware, the RxBonder trial showed chemotherapy benefit differed based on menopausal status. And so for patients who were premenopausal, even if they were node positive, there appeared to be benefit from chemotherapy regardless of oncotype score. And then also just a background point, lower AMH levels reflect fewer growing follicles. It's a more stable and reliable test than FSH and estradiol, and it decreases prior to menopause or prior to us seeing changes in FSH elevation. So it's a bit of an earlier reflector of patients who may be entering menopause. So the objective of the study was to determine chemotherapy benefit in patients who are less than 55 years old using other serum markers of ovarian function and reserve. And again, for the sake of this talk, we're going to be focusing on AMH, as that was the most exciting result. So the population in this analysis included patients who are less than 55 years old and had pre-treatment serum available and analyzed. Patients could be defined as premenopausal or postmenopausal. And the majority of patients, as you can see, fell into the premenopausal group. And so here they looked at whether serum levels of different factors could predict chemotherapy benefit in premenopausal women who were less than 55 years old. And so here you can see with AMH, the chemotherapy benefit was significant for patients who had an AMH less than 10. No other biomarker met that same metric aside from LH, which again is a later predictor. So here they looked at premenopausal patients who were less than 55 years old and found that low AMH had no difference in IDFS benefit with chemotherapy. And they found that patients with medium or high AMH levels had a 7 to 8% improvement in 5-year IDFS with chemotherapy. And then here they looked at premenopausal patients less than 55 years, again with low AMH, and describing no major difference in DRFS in patients with low AMH versus a 4.4% improvement in 5-year DRFS with chemotherapy. So the main takeaway from that was that AMH may be an earlier and better predictor of menopause, and for our patients who are particularly patients who are between 50 to 55 and their menopausal status is less clear, AMH may help us better predict which of these patients may get benefit from chemotherapy. So that that is all I had. Happy to take questions.
I think one of the questions that I came away with was there was some discussion about how you measure AMH and how our, is the laboratory measure that we use here, is that something that we can kind of take home and use with us?
Yeah, and I think in their study I didn't show this slide, but they had both their own ELISA test and a standard lab testing and showed that those results ended up being similar between their more homegrown assay and standard lab testing. But I would have to check how our AMH is run here and what that test is. I don't know if you know, Jen.
I don't recall off immediately, but I think that was one of the concerns, was I think whether it was the way the assay and what the levels that we would consider, whether those were translatable.
Right, but the real question is so is the entirety of the benefit of chemotherapy, is it that you ablated ovarian function, or is there another role?
I mean, the real question is the offset study, which we're soon to open, really, I hope, incorporates AMH levels, because that would be the way that hopefully we can help answer that, although it's going to take years, but it would be great to include it in that study. Well, many thanks, Lynn and Vidya. Thanks for a great job. But give me a thumbs up from Nancy as well. I hope everyone has a great rest of their August and summer. We will look to our next meeting in the next month. And I know there may be a few other topics that we want to cover, but we will look forward to seeing everyone. Thank you for joining, and have a great day.